can all see my screen, hopefully. Yeah, we're good.
Yep.
Okay. Have you guys gone through the trauma guidelines? Like, have you gone through the papers?
Yeah, we have.
Okay. So did you do all three? There's the pediatric one, the avulsions one, and the luxations and fractures one.
I think so. It was like a lecture with Dr. Rose, so we did go through a lot of it. So yeah.
Okay. Okay. So these guidelines get updated usually every 3 to 5 years, depending on when they have new research. So this is one thing. As endodontists, we are definitely experts in trauma, and because of that, it is something you want to keep up on. So just kind of keep an eye on it. The International Association for Dental Traumatology is the IADT, and there is their website. So if you don't have this saved on your browser, I would highly recommend it because it'll give you access to all of it. I would recommend all of your referring dentists have this available as well. If you have kids who were playing in sports teams, anything like that, it's a very, very useful site for giving you all the information you could have. This is a expanded lecture that I gave to my Spear Study Club on trauma. So I'm hoping to get through fractures and luxations today. I don't think we're going to get through avulsions because it's so much. So if you guys have questions, please don't hesitate to interrupt me because trauma's a fun one, obviously. So the first thing is, how do we do our exam when it comes to trauma? So a patient comes in and they've had some sort of trauma. What do we need to look at? Now, this is a very long paper. If you guys haven't read this one, I would recommend going through it as well. I found it very useful just to remember all the different things, but I'm going to quick summarize it for you. The first thing you need to figure out is this a real emergency or is this a dental emergency? Most of the time when I see patients for trauma, I am not the first doctor they've seen. They've usually been through the emergency room. Sometimes they've been to their general dentist. Sometimes they've been to their pediatric dentist or an oral surgeon. So I'm usually one of the last stops. So this isn't something I have to do as often. However, I do want you guys to know the information for if you were to have a patient, car accident outside your office and they come in and say, hey, I broke my tooth. You need to assess a few different things. If there's head and neck trauma, they have to go to the emergency room, obviously. If they cannot remember the accident or if they lost consciousness, they need to be evaluated by a physician. Even if they've had an avulsion, even if they've had a nasty luxation, make sure they're safe first, then deal with the tooth stuff. Do they have any mental issues, headache, blurred vision, slurred speech, anything like that? And then if you cannot find the fragment and they think they may have had it aspirate into their lungs, they also need to have that removed emergently. You don't want them to that can cause pneumonia and all sorts of bad things as well. So if you suspect any of these, get them to the emergency room first. They'll clean them up and then they'll get you after. Now, let's say they've all been through that. One of the questions you have to ask every single time is, do you have a tetanus vaccination? Most people do. However, they may not remember when they last had it. It does expire after 10 years. It kind of wears off. So you do need to update it regularly. For most kids, they'll need it before they go into school, but it is a very important thing, especially if there's been an avulsion. The risk of tetanus is high if it went into things like soil. And so tetanus will, kill you. So you don't want that. First step is control bleeding. So if there's lacerations or any gingival bleeding, usually just pressure is all you need to do. If it's really deep, you can do some light suturing. I haven't really had to do too much of this besides just a little bit of pressure. Avulsions, luxations, or if the root fracture has been displaced, all of these are considered a dental emergency, and you should see them as soon as possible. If it's a crown fracture, the tooth is concussed or just subluxated, that can wait a few days. It's not a true emergency. If someone calls you on the weekend and say, oh, my kid broke my tooth, they don't need to drop everything and come in. You can usually wait a couple days and it's totally fine. I'm going to show some cases along the way as well. Now, once you see the patient, you want to make sure there's been no bone fractures. So you want to palpate all along the face, along the margins, and especially the TMJ, depending on the type of injury. I'm going to go pretty in depth as the different types of injuries that the patient can have and what you need to be concerned about. If you have dental exposure, you do want to cover those tubules, either with a new crown on top of it, or if you have the fragment, a new filling, whatever it may be. The reason why is you can get bacterial penetration through the dental tubules. And when you have trauma, you actually have less blood flow sometimes to the tooth, and it makes it easier for bacteria to get inside there. So that's why you want to cover those tubules ASAP. Make sure you tell the patient, find the tooth fragments. I will show you a case where I made the dad, go back to the playground and find the tooth fragment, because it's such a better aesthetic and clinical result if you can have the actual tooth fragment rather than trying to build it up in composite. Sometimes they can't find it. Sometimes it's, they're out on the lake and get hit, and well, it's at the bottom of the lake. I don't expect them to go find that one. But if they can find it, make sure they find the tooth fragments, and especially if the tooth was avulsed. We'll talk a lot about that when we talk about avulsions. If it's a complicated fracture, which means that the pulp tissue has been exposed, you need to see them within 1 to 2 days, just because the bacterial penetration is about 1 millimeter per day. And so you want to get them before the tooth becomes necrotic. You can usually do a pulpotomy or just a pulp cap and get the tooth to stay alive, which is really good. The other thing to look at is if there's any soft tissue injuries. Like I said, sometimes you got to suture it. Sometimes you got to just pressure to control it. It kind of depends. And we'll talk about this with radiographs. But if you can't find the fragment and there is an entry wound into, say, the lip, you're going to want to do a soft tissue x-ray to make sure that the tooth isn't, embedded in the lip. Okay. As far as the records, I have thankfully not had to be involved in too many of these cases, but most of the time when there's trauma, there is, if someone else is at fault, then you have to deal with all this. My recommendation is if somebody comes in, and I'll show you a case here where a lady was in a very bad motorcycle accident, actually lost her leg and ended up needing root canals on 6 through 10 because of the extent of the trauma, because it was so bad. Now, the person at fault, the guy who hit her, his insurance paid for it. But the thing is, they're not going to pay me. I have tried to do this before. If you've ever been involved with any insurance things, my recommendation 100% of the time, make the patient pay you. Then you give them the invoice with everything. It goes back to the insurance company, whoever's at fault, and then the insurance company will cut a check to the patient. The insurance company has obligation to pay the patient, obviously, because they were the one who was at fault. They don't have an obligation to pay me. And the couple times I've done it where I try to get paid directly by the insurance, I don't get paid. So my recommendation, if you have to deal with any litigation, if there's somebody else at fault and lawyers or insurances involved, make sure you have the patient pay you directly and then get reimbursed by their insurance. You can tell I'm still a little bit sour about that. Now, what I record every single time is when and where did the injury occur, and I ask quite a lot of questions about the type of injury as well, because it gives you a clue as to what type of injury could be hiding that you're not aware of. You need to know how the injury occurred, and then are there legal implications? So is someone else at fault? Is this a case of abuse? Anything like that, you need to make sure. Pretty much anytime I see a trauma patient, I am going to assume that a lawyer is going to eventually look over the records at some point. Thankfully, that doesn't happen too often, but just be a little bit extra as far as your note taking and make sure you have a very clear narrative for everything. Okay. Once again, if there's insurance implications, run away from that. Have the patient pay you directly. Do not have the insurance company pay you, because they will not do it. And then, was there a third party involved in the accident? And that's where you have to be concerned of, is there some legal implications that you need to just prepare yourself for? You are not going to be at risk of getting sued or anything, but you're just helping patients out. However, your records may be in front of a courtroom, so just keep that in the back of your head. Okay. 2 slightly awkward questions that you do have to ask yourself. Are the injuries consistent with the reported cause? Is the bruising fresh, or is that a week old? Is this consistent with, the kid falling and hurting himself, or is it consistent with abuse? We are mandated reporters if we are suspecting of it. The other question is, and this is more for if you see the patient at the time of the injury, is do you feel safe? If you're concerned that they may be under the influence of alcohol or drugs, which could have led to the accident in the first place, or if you feel that they're not in the right mental state, you do not have a duty to treat either an intoxicated or threatening patient. You can say, I don't feel safe here, or whatever it is, and let them go. So you do not have to treat a patient if they're threatening you or if you feel like they're a danger to others. Any questions so far? I know these are the awkward ones we never like talking about. No? Good. I thankfully have not had to do any reporting things. I haven't seen any things of that. I've seen a lot of car accidents where the insurance gets involved, and that's where it's a little bit fun. Okay. So different factors to consider is how did the injury occur? How much energy was there when the tooth got traumatized? So was it my little daughter accidentally jumping up and hitting me in the tooth, or was it a motorcycle accident so severe that she lost her leg? There's a very big difference in the amount of force that was applied to the patient in both of those situations. And it gives you a clue of what type of damage it could be. If it's a lesser injury, it's probably just going to be a concussion, maybe a subluxation. If it's a big one, you're going to want to check multiple teeth. On her, I actually tested from 4 through 13 because I was worried that there might be some other issues there. How hard or soft is the object? So there's a big difference between a kid who runs into another kid and causes, there's the compression of the other kid versus they run into a wall. And I'll show you one where a kid did run into a wall. What was the size and the shape of the object? So are they running into a flat thing like a wall? Did they get hit in the face with something large like a basketball? Or was it a small, like, oh, a golf ball hit me in the face? So it very much changes what type of injury you're looking for based on the size and shape and how hard the object is. Is it sharp or is it blunt? So is it something big that's going to deform, or is it something that has an edge and is going to cause localized damage? It gives you a clue of how many teeth you need to look at, and should you be looking at other areas as well. What is the direction of the force? Was it they fell on their chin and they hit the teeth moving up? Was it a lateral force? Was it down? Is pretty rare. It's pretty hard to get forces going this way in general. But you need to figure out which direction did that trauma come at the patient, and it gives you a clue of which areas to look at. Anything that involves the chin or anything like that, you want to be checking their TMJ for damage. And I'll talk about that in a little bit as well. What is the size of the face? Do they have a giant pumpkin head like me, or are they a tiny person? Obviously, someone who has a giant head, they're going to have, if they're getting hit by something small, you would expect the trauma to be in a small area. If it's big, you kind of get the idea there. Okay. Is the tooth open or closed? 1 millimeter is kind of that golden rule for if you can get the tooth to revascularize, keep growing. I'll show you cases, especially with avulsion, on how we handle that. How strong or resilient is the supporting bone? So how many of you have done a lot of extractions? Did anyone do like GPRs or anything like that? Cool. All right. How easy is it to take out teeth on young people? Pretty easy, right? The bone deforms, things don't break. How easy it is to take out teeth on 80-year-olds? Not quite as easy, right? Bone becomes more dense, less supple as we age, and you will therefore see far more luxations or avulsions in kids because the bone is so soft. The tooth is the hardest thing, and that goes. And in adults, especially the elderly, you're going to see far more fractures or root fractures because the bone doesn't give anymore. So it pushes more of the force down into the tooth. So I really have not seen any avulsions on anyone over the age of, I'd say 40, really. Most of the time you're seeing fractures, sometimes luxations, but for kids, you really don't see that many fractures unless there's, I'm actually going to show you a kid with one fracture, but it's mostly luxations and avulsions. What is the soft tissue in between it? There's a big difference between somebody who has competent lips and they get hit with with the mouth kind of protecting it, versus a kid who's out here with buck teeth, runs into the wall with his mouth open, nothing supporting it, and the teeth take the whole brunt of it. Where was the tooth struck? So was it on the incisal? Was it facial? Those are pretty much the only two. And then is this from direct trauma, which is something directly hitting the teeth, or is it the teeth smacked together because they landed on their chin or something like that? Any questions about this? All right. I don't ask my patients every single one of these questions. I usually do a sampling based on what the trauma is and what they told me. So, I mean, obviously on the motorcycle patient, it's clear she lost her leg. The energy was high. I'm not going to say like, well, was it a bad accident? Like that's kind of a dick move. But you want to know, what did you land on? Cycling, I'll actually have a lot where they'll end up on hitting the handlebars or flip over. We're a big mountain biking community. Right now, it's all skiing is what the what the injuries are, but it'll switch to mountain biking here in a little bit. So most of my pediatric patients, the injury is going to occur on the playground. So they're running, they trip. They fall and hit their face on the slide, on another kid, on a pole, on the swing, on the concrete, on the wall, on a tree. Kids are very clumsy. That's what that's what I'll tell you. Most of my adult patients, on the other hand, does anyone guess what causes, I'd say, 90% of my adult patients' trauma?
Car accidents.
What'd you say?
Car accidents.
Nope. These
Gosh.
scooters. We don't have as many here in Reno, but all of my friends who live in big cities, they get a scooter accident a week. We just started to see more scooters in Reno, and I've seen a huge uptick in trauma as well. So be careful when you're riding scooters. Don't do it while drunk. There's my PSA for the day. Okay. If we see discoloration, and this is a common occurrence, there's different types of discoloration and they mean different things. So if you're seeing pink or purple, you can think of that as bleeding inside the tooth. Now, sometimes it can actually resolve over time without you having to do any treatment whatsoever. And we'll talk about kind of how I choose which cases I go into treat and which ones I monitor. If it then starts to turn gray, now we're seeing necrosis and a breakdown of the blood byproducts inside there. And on these cases, it's usually going to be necrotic. One thing to consider is if you have that pink or purple, that's kind of the bleeding, you will actually see the tooth go through the colors as if you had a bruise on your body. So it'll be that kind of dark purple. Eventually, it'll kind of be yellow as the body breaks down those dead blood cells. And eventually it'll go back to normal. So this is where photos and kind of getting a baseline is incredibly important. Once it becomes like a dark gray or especially a brown, at that point, the tooth has been dead for a while. So that those, does everyone know how teeth stain from the inside out? The actual process of it? So what happens is when you have necrosis inside a tooth like this, if it's not from something like, the material being stained, what happens is the necrotic products, that's a fun word. They start to build up over time and it forms these really long chain compounds that get stuck inside the teeth. Those long chain compounds then absorb more of the light as it hits the tooth and makes the tooth look darker. That's why when we do the bleaching, the sodium perborate breaks down into hydrogen peroxide and that ion goes through and cuts all those pieces up into really small ones. And that's how the bleaching process works. So there you go. If you see yellow teeth, on the other hand, this is usually from calcification. This is a chronic process. I showed you guys during the I think it was last time, right? Where you can do the bleaching without having to do the root canal sometimes. Yes. Does this sound familiar? Yes. Perfect. All right. In this case, this was you can see this tooth, unfortunately, was not savable. That's what caused the discoloration on this guy. All right. What x-rays do we need to take? The most important thing here is establishing a baseline. What do the teeth look like at the time of the accident or as soon as possible compared to a month later, 2 months later, 6 months later, et cetera? Because with all of trauma, the most important thing is following up with these patients to make sure nothing happens. So I put duh on there because in the guideline, it talked about doing anterior versus posterior. And I'm like, I've never seen posterior trauma, so I don't know why you would put that on there. Most of my 8 and 9 cases, actually, I'll go through this later, but most of my 8 and 9 cases are trauma cases. They've either had trauma in the past or I'm catching them right after they had trauma. If you're at an office that doesn't have a cone beam, this is what they recommend. You need to take a midline PA of 8 and 9. You need to take laterals centered on both 7 and 10. So you're picking up that 6 through 11 at different angles. That allows you to see things like fractures or potentially bony fractures, any displacement of the teeth out of the socket as well. And then you also recommend taking an occlusal radiograph. Does everyone here know how to take an occlusal radiograph? Does anyone not know how to take an occlusal radiograph? It's okay. All right.
I've never taken one.
You've never taken one? Perfect. What you do is you take the sensor and you're going to put it like this behind the front teeth, literally touching it. So I usually just kind of hold it up there and then you shoot right down on top of the nose. It's going to be a very distorted image, but it is one of the best, if you don't have a cone beam, for locating where root fractures are located. So very useful if you're concerned about that. It's also useful if you have a pediatric patient that has mixed dentition and you're worried about the primary tooth intruding and causing damage to the adult tooth. This is a good way to see where they are located. Sometimes, depending on the type of trauma, it's useful to take x-rays of the lower incisors as well if there's been trauma down there, obviously. If you're concerned about anything with the TMJ, take a pano. If you're going to an office and you're setting it up from scratch, I would recommend getting a cone beam that gives you the ability to take a pano image. I don't use it all the time, but I'm very happy I have that when I do. So if you're going to an office that already has something, you kind of are stuck with it. But if you get to choose what you want from scratch, I would recommend having one that gives you the ability to do a pano because it is a very useful image, especially in children and trauma. Soft tissue x-rays. I know I kind of talked about this one. Does everyone know how to do a soft tissue x-ray? So it's pretty easy. You're going to take the sensor. You're going to put it between it's usually the lip. You're checking to see if there's a tooth fragment in there. Put it between the lip and then shoot the x-ray up right on top of that. You just hold it by your hand. And if there's anything calcified in there, you'll see it right away, obviously. The question you really need to ask for any of the x-rays is, will this image change how you're going to treat the patient? And you realize there's one image I haven't talked about, and it's this. The cone beam is incredibly, incredibly useful. I know we want to minimize radiation to patients no matter what. The cone beam can replace 90% of these images at once. It is so incredibly useful. I'll do a slightly larger field so I can at least pick up 6 through 11. Make sure that there's no facial fractures, anything like that. As far as what I do for radiographs, I'm usually going to take 1 to 2 PAs just to see different angles. Just sometimes the two-dimensional images are easier to see things in. And then every single time I'm taking a cone beam because it's so useful. And I'll show you why in a little bit. I really don't have to do the other images too often. Since being the cone beam, I don't really do occlusals much anymore. Once again, if you have a cone beam, use it, especially on kids. Okay. All right. Photos. I highly recommend all of you get cameras attached to your microscopes. It has been one of the best practice builders for me. It's great for documentation. I had one dentist, never really worked with him, and his patient found me, and he had done a couple of root canals, missed the MB2s on 14 and 15. And this guy called me up in a tizzy saying that if I didn't show him proof that he missed the MB2, he was going to sue me for defamation of character, which is hilarious. So what I did is I took the 2 pictures that I always take, circled where his missed MB2 was, and sent it back to him. And I never heard from him again. So I highly recommend learning how to take photos. Set that up as part of your office, that the culture is you're going to take photos from day 1 because it's incredibly useful. All right. So as far as what I do, I'm going to take a few extra photos than I would normally for trauma just because of that, litigation potential. I'm usually going to take a picture of the tooth. If there's any soft tissue damage, I'm going to take that. Any surrounding area, so if there's lacerations inside the gums, anything like that, I usually want to get at least 6 through 11 in the image. So if there's any discoloration in the future, I can compare it to what it was in the past. And then if you're concerned about litigation or abuse or anything like that, take a picture of the face as well. I usually will just use, we have a little webcam up front that we take a picture of for every patient so we know what they all look like. That's usually sufficient, but if there's something specific that you're concerned about, I would take a close-up as that as well. So here's a case that came in recently. She has really bad vertigo and stood up and just fell forward. So she had some gingival bleeding, so I wanted to take a photo of that because that's definitely unique. You want to make sure that goes away. I took a picture of the soft tissue showing the damages to her face, and then I also took a picture of 6 through 11 kind of showing what they all look like. Pulp testing. All right. So with pulp testing, it's incredibly important and also not important at all. Your main key thing, as always with pulp testing, is going to be cold, using endo ice, seeing if it responds. Now, the reason I say it's incredibly important, but also not, is because it's very unreliable at the time of the accident. There's a couple reasons for that. I don't use percussion. These teeth have just been hit. Why would you hit them again? I think percussion is the dumbest pulp test we could ever do. I would recommend everybody stop doing it. It's incredibly useless unless you're worried about ankylosis. Has anyone tapped on a tooth when it's ankylosed? Do you guys know what it sounds like? That's what it sounds like when you tap on a tooth that has been ankylosed. It literally sounds completely different, and you can hear it throughout the entire room. So that's the only time I'll do percussion. The rest of the time, take it out of your repertoire, just do biting. It's more useful and it doesn't hurt your patient. All of the tests at this point are going to be incredibly unreliable, and that is because you can have a transient lack of response from the trauma itself. Like I said, there can be differences in blood flow when it gets in there, so that can also be differences in nerve conduction. And in kids, what happens is your A delta fibers have not actually matured all the way. If you ever tested a tooth with an open apex and either has no response or a delayed response, that's because those A delta fibers have not had the time to mature. And once it closes, that's when you'll start to see that. Now, what I still do, I haven't done the next one. So here's an example of a case where I thought this was trauma. This is a patient I saw actually yesterday. So 34-year-old female, no history of pain. And she said she doesn't remember ever getting hit in the face. Now, it could be something that happened when she was 10 and she forgot about it. There's lots of different things. What's weird is this tooth felt cold. Actually, 22 through 27 were identical in all of their testing. My concern is that it's a mixed radiolucent, radiopaque finding with a little bit of expansion and palpation sensitivity. So I'm thinking something more pathological here. So this patient is seeing the oral surgeon that I work with to get a biopsy and figure out what it is. This is why we always want to cold test, because had I not cold tested this, you could see me saying, oh, 24 needs a root canal. It's got a big, lesion on it. And if you don't cold test, you can miss things like that and delay treatment of something that could be invasive or really bad. As far as what I do, I test and record 6 through 11 at a minimum every single time. I'm going to do palpation. I will do biting tests to see if it's sensitive. And if it's mobile, don't torture your patients, obviously. But with the cold, I am going to just write down what it is. Because of that transient lack of response, I do not base any treatment decisions off of the cold test for at least 2 to 4 weeks until I see them back. And even then, it's going to be based more off of symptoms rather than the cold response. Now, the type of injury often is going to determine treatment. So it doesn't matter if an intrusion doesn't feel cold or it does. Your risk of resorption is so high, you're going to be doing treatment on it anyway. Same thing with avulsions, same things with the really bad accidents. That's going to dictate your treatment rather than the cold test. But especially if the type of trauma was blunt and could hit multiple teeth, it's really important that you establish a baseline, because there's a big difference between, let's say they get hit in the face with a baseball, 9's fractured, you need to do a root canal on it. 10 feels the cold. They come back in a month, all of a sudden 10 doesn't feel the cold. Now, what does that tell you? It's a call and response, guys.
That's probably going necrotic.
It's probably going necrotic. Versus it didn't feel the cold and a month later it still doesn't feel the cold, but they're not having any pain on it. Well, it could just be transient and you just need to follow up with them more. And ideally, it didn't feel the cold, then it feels the cold. So I will follow up with patients. I put on each one what my follow-up is. I always repeat this cold test from 6 through 11. So, in TDO where it has the multi-tooth info, all the trauma ones are super, super, super long because I do multiple tests, but it's so important to have that baseline to compare to. You should not initiate the root canal unless there's confirmed evidence of pulpal necrosis. So with certain types of injuries, avulsions, intrusions on closed apices, really bad lateral luxations, the tooth's going to die. The risk of resorption is really high. You need to get in there and do the calcium hydroxide right away. With other cases, and this is, did anyone see the video I posted last week of the kiddo with the pulp cap? It's fine if not. That was one of the most common questions was, when will you do the root canal? And my response is hopefully never. Until it is proven to me that the tooth is dead, try to keep it alive as much as possible. Now, like I said, any tooth that has a closed root and is either avulsed or intruded has a very, very high risk of resorption. And so I will start the root canal and get calcium hydroxide in there as soon as possible. Any questions on pulp testing? This is one that kind of confuses a lot of people.
You may not have the answer to this. I'm just curious if maybe you've seen the same more trauma cases. Do you find that patients recovering from trauma, when you see them 4 weeks later, they are starting to feel cold, or those that feel nothing 4 weeks later? Is there any indication? Have you seen one or the other go either way? I don't know if that's kind of a confusing question. It probably is from my wording, but
no, you
you know what I'm getting at.
No, just to rephrase your question, the question is, how often do we see it where they don't feel cold and all of a sudden they do a month later?
Yeah, and then like, or I guess,
And vice versa?
yeah, or then if you see a patient that like continually isn't feeling cold at these follow-ups and then regaining that cold sensation, like, I don't know, I guess
There's, yeah.
that,
So to answer your first question, all the time for they don't feel cold, it comes back, they feel cold. That happens all the time. I would say half of my trauma cases have that exact same thing happen. So that's why it's important to do it. The reverse, where it doesn't feel it, it still doesn't feel it, and still doesn't feel it. It's kind of a tough situation where you just have to monitor it and see if there's any other signs of pulp necrosis besides the lack of cold response. Because it could be, I've seen trauma where it takes, a few months for everything to go back to normal, depending on the extent of the trauma. That motorcycle accident I was talking about, I eventually did do 6 through 10, but initially only 6, sorry, I think it was only 8 through 10 that were confirmed really bad luxations, needed treatment right away. 6, 7, and 6 and 7 were actually vital. And she came back probably 6 months later and started to have pain on those teeth, and they were necrotic at that time. So this is why follow-up is so important. But as far as like when would you have like I think your question is, all right, we keep testing it, it's negative. Do I need to do the root canal? The answer is I would go off of other symptoms rather than the cold to say, yes, we need to initiate treatment. Did that answer your question?
yeah.
Okay. With all of trauma, and I'll talk about this too, of how I communicate with the patients with trauma, your crystal ball is completely cloudy. You cannot see the future. I've had so many cases on 50-year-olds where they're like, oh yeah, I played baseball and I got hit and I popped it back into place. And I was 16 when that happened. And 34 years later, now it's hurting. I see that all the time. I've also seen cases where they have the trauma and it goes back to normal and they're good. It kind of just depends. So a lot of it depends. All right. Do we need to give these patients antibiotics? Most of the time, no. Most of the time, either the emergency room or their general dentist will put them on it prophylactically anyway, so you don't have to worry about this. The only time where you do need to do antibiotics is avulsions. Because if the tooth landed on something, it probably got bacteria on it. You do need to protect them with that. Amoxicillin is a great one for this. You can also use tetracycline or doxycycline as long as they're over the age of 12. It actually has a really good anti-resorptive effect. Tetracyclines play weirdly with calcium, and so it can really help prevent resorption, which is kind of cool. So if you have an older patient who had an avulsion and they need antibiotic coverage, as long as they're not allergic, I would actually use doxycycline in those cases, and I very, very rarely use that. Okay, the general strategy for trauma. If possible, save the pulp. Do the pulp cap, do hopefully nothing. If the pulp dies, save the tooth. Do the root canal. It's what all of you are very good at doing. If you cannot save the root because you have resorption, it's incredibly important to save the bone. The average age now that's recommended for most females to get an implant is ideally 21, so end of college. And the recommended age for most men is actually 25, so far, far, far after. And if you probably haven't had to see this too often, but if there's no tooth there, the collapse and damage is disfiguring. So you want to do everything in your power to save the bone so that the patient has a chance of looking normal. And sometimes you have to help these patients limp along for a very, very, very long time. Okay. Going through this is actually very interesting because what I did is I went through and looked at I only have access to the last 4 years because that's when I opened the office, and it did all my number 8s and all my number 9s. And what was interesting is probably about 90% of the time with trauma cases, I don't have to do the root canal, which I found really interesting. And over half of my 8 and 9 cases are from some sort of trauma. Both of these I did not anticipate. So you're not going to be seeing a lot of cariously exposed number 8s and 9s because people are, you don't want to have a big hole inside your front tooth, but you will be seeing a lot of trauma cases on these areas. Even if you're not the one necessarily putting the splint on and handling it, you'll probably see them after. So it's important that we as endodontists have a really good understanding of what this means. The other thing is we all look at it as like, oh, this tooth was concussed, this tooth was luxated. What happens is because usually they're hitting something blunt, there's going to be multiple types of trauma within each case. So keep that in the back of your mind that You want to look at it kind of tooth by tooth for this one was avulsed, this one was intruded, this one was luxated, and treat them like that. But you also want to keep the global picture. And like I said, do the testing, make sure you establish a baseline because these have a way of rearing their ugly heads as time goes on. Okay, there's new terminology. How many of you learned the Ellis classification? I think I'm the, I don't know, a few of you? Yeah, that one I think that stopped actually when I was in residency. So now we look at fractures and luxations and avulsions. We're going to go through fractures right now. You can have a uncomplicated crown fracture. You can have a complicated crown fracture. You can have a complicated crown root fracture. You can have a root fracture. There's also an uncomplicated crown root fracture, which I don't know how that's possible. Maybe you just shear it off. But anyway, really all you need to know is if it's complicated, it means the pulp has been exposed. So that would be your Ellis class 3s back in the day. All right. With a uncomplicated crown fracture, the treatment, ideally bond the fragment. You can use bonding agent only. The video I just posted shows how I was able to just use bonding agent and didn't have to use flowable or anything to rebond the tooth fragment. And it gives you a really nice aesthetic result. That's why I say make the parents find the tooth. If you cannot find it for whatever reason, or if it's been lost, composites work great for this sort of thing. Make sure you cover, if you're doing the composite in particular, make sure you cover the exposed dentin with some sort of GI. That fluoride inside there will really help protect the tooth and will help a lot with their sensitivity. So if I'm going to be working on a pediatric patient who has a uncomplicated crown fracture, usually the general dentist can handle this one. I don't do these too often, but my usual strategy is cover all the dentin with a unfilled GI. You can use Fuji 1. You can use Vitrabond. I like Vitrabond the best. There's a bunch of different ones you can use. And the cool part is you don't have to etch or condition it. The unfilled GI actually bonds inherently to dentin and creates a nice, pretty strong bond. And then what I do is after I've filled that, I will go around the outside with a diamond to re-expose all the enamel. And then you have a really strong enamel bond with composite on top of there. Follow-up's just going to be about 6 to 8 weeks. Make sure it's still vital. Most of these cases don't need any other treatment, which is good news here. So here's one where the trauma had occurred. I don't know if it was the emergency room or the dentist did that beautiful looking composite. Ended up doing 2 composites on there, fixed it all up pretty easy. Okay, complicated crown fracture. Now the pulp's been exposed. So at this point, as long as the tooth isn't necrotic, you want to try to save the pulp, even if it's on an adult. Even on adults, if you get them in quickly enough, I still try to do pulp capping. Does everyone know how to perform a spec pulpotomy? You remove the pulp a few millimeters down and then fill it up rather than just doing it on top of it. It's pretty easy. The video I posted shows how I did it because I had to do, I think I went down 1 millimeter or 2 on that kiddo. Make sure you use a modern material. Do not use Dical. Do not use calcium hydroxide. Do not use MTA because the staining with these teeth is insane. I had a couple back when I first started before we had the really, really modern materials, and the staining was just so bad. So modern materials would be something like BC Putty. That's what I use for most of mine. Biodentine works really well. Neo MTA. As long as it doesn't contain either the aluminum or there's a few different reasons why it stains, you do not want to put something that's going to stain on a front tooth because they're going to be back in your chair in 6 months being like, my tooth's gray now. What are you going to do? And that's where it becomes a more difficult conversation. The root canal on these cases is only if it's already necrotic or if the tooth is broken down enough that you need a post to maintain it. You know, if it's sheared off pretty deep and you're worried about the strength of the composite, I would recommend doing the root canal at that point, even if the tooth is vital. Follow up on these is the same, 6 to 8 weeks. Here's a case where she had a complicated crown fracture, but then didn't get in to see me for like 2 months. That's why trauma, you got to get in as soon as possible. You can see from the staining, it was quite extensive there, kind of that grayish color, brownish, you know. So what we ended up doing here for her, and it actually wasn't that bad clinically when we look on the x-ray. What we ended up doing was bleaching the teeth, bleaching that tooth, doing some composites, filling it up, and getting it back to kind of a more normal size. So, okay. Here is actually the case that I did last week. By the way, don't ever make presentations on trauma because you put it out into the world that you just want trauma cases. And I usually get about 1 a month. I think I've had 7 in the last week. It's insane. Like I'm manifesting is trauma cases, and it's just too many. It's too much. So here's a case. This is the kid that ran into a wall. And so here's what the cone beam looks like. Pretty solid there, but you can see, especially in some of the different views here, we're getting really close to the nerve. And when we get inside there, the nerve has been exposed. Now, he had the trauma, I think about 24, 36 hours before. And so I went in and did a small little bit of speck pulpotomy. I just removed probably about 1 to 2 millimeters of pulp tissue. You put a little bit of bleach or EDTA on top of there, make sure it calms down. If the pulp is still bleeding, that's a sign that you may need to remove more tissue. In his case, though, it looked really, really good after that. Used BC putty, just filled that area in. I was able to rebond the fragment and then put a little bit of flowable composite along where the actual crack was. And here's what it looks like in the end. So you can see that tooth, besides that little line right there, it looks really, really good. And the cool part is this will, especially as it ages, it will rehydrate and you won't be able to see anything. And I've seen cases like this go 10, 15, 20 years, no problem, just with bonding agent. That's how powerful that stuff can be. So kind of a cool case. And here's what it looks like. Like I said, about 1 to 2 millimeters is all that I had to remove from that exposed area and rebond the fragment. And we will keep monitoring him. And ideally, tooth will stay vital, won't have to do anything. Any questions on complicated crown fractures?
Why wouldn't you remove more of the coronal pulp? I mean, the fact that it was open for 24 to 30 something 6 hours, you could potentially have some bacteria in the adjacent pulp tissue.
Yep, you can. And you do for sure. But how far do bacteria travel per day? 1 millimeter. So I figured it's been 24 to 36 hours. So let's remove about 2 millimeters because that's about all far the bacteria can go. Put that stuff on top of there and it heals. You want to see the reason why I want to keep the tooth alive is because look at how broad this pulp tissue is. That's going to, I mean, it actually looks pretty solid for, his age. But if we can get this to keep maturing and keep growing, the tooth will be much stronger and the risk of a fracture down the road is going to be far low, like a vertical root fracture or a split or anything like that is going to be far lower. Good question. Any other questions on complicated crown fractures? Cool. All right. Root fractures. So these are always fun. You do need splints. How many of you learned that you need to do rigid splints for root fractures? I did. Cool. We don't do rigid splints at all anymore. No more. You need to do these short term, 2 to 4 weeks maximum, because anything beyond that, you start to greatly increase the risk of resorption. You do not want to put any force on the teeth whatsoever. And I'll show you kind of how I do that when I make my splints. As far as the type, you want it to be pretty flexible. So less than 0.4 millimeters, which I think is like a 0.16. I think that's the thickest you want to do. I'm terrible at ortho. I never wanted to do ortho and don't. I like Ribond because it's easy to apply and it's that perfect level of flexibility. And it's a little more aesthetic, I think, than having the wire on top of there. But the problem with all root fractures is there's like 100 different ways it can go. And so you don't really have a clear flow chart for if this, then that. You kind of have to take every case differently and see what it gives you. So the other thing to remember is the prognosis is often much, much, much better than you expect. I polled the spear audience, and most of them thought that if the tooth if it was a root fracture, it either 100% needed a root canal or 100% needed to be extracted and replaced with an implant. And I'll show you sometimes in a case like this, where the patient doesn't get back to you for 2 weeks, there's no magic fairy dust I can use to fix that one. That one's coming out. Unfortunately, that one's going to be extracted. However, in a case like this, can we all see the fracture on there? Hopefully it's pretty obvious. You can see one line right here, one line right here. Okay. How many of you think that because it's so coronal, that tooth needs to be extracted or is going to have some problems? Just raise your hands. Nobody? You're all so smart. I also said right over here, though, the prognosis is better. That's what it looks like on the cone beam. Now, how many of you think there's going to be a problem? So if you look closely on the cone beam, just give you a heads up. This trauma occurred a year and a half before I saw the patient. He just pushed the tooth back in, never went to see a dentist. I see a lot of farmers who are pretty tough and had no problem. He just went to a new dentist who saw it and was like, get this checked out. If you look closely, you can actually see there has been hard tissue forming. That is bone right there. That tooth is going to be totally fine. It was still vital, had no issues. I said, we'll follow you up and make sure there's nothing wrong with it. He's good to go. Here's another one. This is a basketball player that I worked on. Elbow to the face. It's probably one of the only like, especially if you're coming down on somebody, it's probably the only time you can have a tooth extrude this way. So here were the images there. Here's what the tooth looked like. You can see multiple craze lines running along because of the force on there. And the tooth has been displaced about a millimeter and a half. So what's the cone beam look like? Where the hell's my cone beam picture? Well, my cone beam picture is right there. It has a crack that kind of runs pretty high. Not too good. What we did, the tooth was still vital at that point, so I just repositioned everything. Now, when you make a splint, I'll talk about this in a little bit. What I recommend is doing 2 teeth on either side, and you bond all of these stable teeth first. So what I did is I did these two, make sure there's no ortho force. And then because I had to push his tooth in, what I did is repositioned it. And while I was holding it, had the assistant hand me the flowable. You can see there's a lot more flowable on the traumatized tooth just because I want to make sure it stays in place. And then they come in and quick snap cure it so that everything looks good. Take an x-ray, make sure it looks good. 4 weeks later, he came back. Tooth was still vital, no issues whatsoever. I follow him on Twitter. He's still playing basketball and doing great, and he still has his tooth from what I can see. So we'll call that a win. All right. Any questions on root fractures? I'm really sorry that cone beam didn't show. When I post the video, I'll put it in there so everybody can see what it looks like. But alveolar fractures. Have any of you treated these cases?
GPR.
GPR, badass. Yeah. My recommendation: don't do it. Find yourself an oral surgeon. This is mine. He does all the alveolar fractures that I see. Most of the time, it's going to be splint them and usually use the teeth to help support the bone. Depending on how bad the bone is, sometimes they got to remove it. It can get really, really complicated, and it's not something you want to deal with. I assume most of you are going to be going to larger communities where you will have multiple oral surgeons. They usually take trauma call with either ENT or plastics at the local hospital. And so I'd say most of the alveolar fractures actually go to see Chris first, because that's more of an emergency if they've had enough of an injury that they broke their bone. And then I see him after. So very, very rarely do I have to manage any of these. And most of the time, he just says splint him and monitor him. So that's good news. Okay. How are we doing time-wise? I can probably get through the couple luxations, then we'll call it a day. Any questions so far on fractures, anything like that? Good. All right, luxations. Your main question is whether or not the apex is closed. So remember, a millimeter is our number. What you want to do is avoid adverse outcomes with luxations. And so your adverse outcomes are going to either be one of 2 things: pulpal necrosis, which means you need to do the root canal, or resorption. And the reason why is because the cementum is the protective layer on the outside portion of the tooth. If you lose 20% of that cementum, you are going to have resorption 100% of the time. That can be from things like it getting scraped off as it's either intruded or laterally luxated. That can be from an avulsion causing death of the PDL cells. That can just be because trauma is weird and it causes things like that. There's no rhyme or reason to any of this. The key to resorption is to get calcium hydroxide inside those teeth as soon as possible and leave it there. I'll talk about how we do this in a little bit, but what calcium hydroxide does, because it is so basic, it inhibits osteoclast activity, so they can no longer attack the tooth. And over time, it actually causes reformation of the cementum barrier inside there. So it has 2 great effects. It takes on average 4 weeks for calcium hydroxide to change the pH from the inside to the outside of the tooth. And I like to go at least 6 weeks on all these cases. What I do with calcium hydroxide is after placing it, we'll take an x-ray that day. When I see the patient back in 6 weeks, I'm going to take another x-ray before I even get inside there. And you would be surprised how often that calcium hydroxide is gone. Either the infection or something else has eaten away all of it. And that's a cue to you that you have to change the calcium hydroxide. My worst case by far for calcium hydroxide use was one where a general dentist had this nice gal. She went over the handlebars of her bike, avulsed 8 and 9. He replanted them, did a rigid splint using composite, and didn't do anything for 4 months. Okay. What do you think happened? Those teeth were super necrotic, obviously, and they all had pretty bad resorption. So, I think she's like 35-year-old. She wants to keep her front teeth, obviously. So, what we ended up having to do is change the calcium hydroxide. And I would see her every 6 weeks. She actually lived in Truckee, so it's a bit of a hike for her to come out here to see me. I would change it every 6 weeks until we finally got it to calm down. I think number 8 was the worst one. That actually took 9 months of calcium hydroxide changes before it finally was stable. And I could see there was bone fill into the resorption rather than it being active. 9 only took a couple changes. So on these cases with resorption, be prepared that you're going to be married to the patient and you're going to see them quite a lot. Why don't we start luxations next? Do you all have patients here in 5 minutes, I presume? Yeah. Okay. Let's go ahead.
How do you financially address these luxation patients? That might be a patient for you for 9 months. Right?
Oh God, that's the I'm going to tell you right now. Any trauma cases, you're going to lose money. Period. It just you're doing it for the love of the game. There's no real good way to charge from. I just consider those kind of well, you get what you can. You can always charge the consult fees, the x-rays along the way. You can charge the root canal and post if you end up doing them, but it is going to be multiple appointments. The good news is most of the time they're super quick. How long does it take you to get a nerve out of a wide open number 8? 5 minutes. I mean, it's really this is the one time when those pro taper shapes are perfect because they're perfectly shaped for number 8. Like I use F1 on most of these cases. It fits it perfectly, rips it all out. We rinse a bunch, put calcium hydroxide, and I'm done in 10 minutes. So on these, well, it is going to be multiple appointments. They're shorter and you can do them almost as side books. I would still recommend getting patients numb. I know some people who don't for calcium hydroxide changes, but I think it's worth getting them numb. But if you know that you're going to be having to see them multiple times, just plan on like that being a 15-minute slot. And that way it doesn't eat up the full hour and a half of your time. So that's one thing you can do. Yeah, I've heard of people billing medical insurance, but you don't really want to deal with medical insurance. That's a whole nother mess of can of worms. Unfortunately, like I said, it's a lot of appointments and you're not going to be in the black with most of these, unfortunately. But no one else is going to see them, especially kids. And I would highly recommend all of you learn how to sedate patients, especially kids, because they're, like I said, they're very straightforward cases. And it's a great service you can provide to the community. So any other questions? Cool. All right. So we'll call it a day. We'll go through luxations and hopefully get through avulsions. I knew this one was going to be a big one. Unfortunately, that's how it is. If you haven't read the papers, highly recommend looking it up. It's that dentaltraumaguide.com, and it'll get you to the papers. They're all free. You can download them, look through them. They're all like 50 pages long. That's why it's taken a minute here. But there's going to be one on specifically pediatric trauma on immature teeth. Really, if it's a baby tooth, it's generally either take it out or leave it if it hasn't caused damage. But if it's going to cause damage to the adult tooth, take it out. Most pediatric dentists are amazing at trauma. They're really good at it. I never get referred patients from pedo unless they're an older patient who needs some help. And usually it's just, oh, they need a root canal and I can't do it. Most pediatric dentists are really good with trauma. And then the next one is the fractures and luxations. That's another 50-page pager. And then, like I said, avulsions is its own paper on its own. So cool. All right, guys. Any other questions? Fantastic. I will see you online in March then and in person at the AAE. So it's going to be fun. Cool. Feel free to call or text if you need anything. Bye, guys.